Good morning, everyone, and thank you for joining us, and welcome to the Cardiology Grand Rounds here at the Methodist DeBakey Heart and Vascular Center. My name is Joe Kim, and I'm an advanced heart failure and transplant cardiologist here, and I have the pleasure of being one of the associate program directors for the Cardiology Fellowship. And it's really my distinct pleasure to welcome our two speakers for Grand Rounds today. A few years ago, we began this tradition of our graduating cardiology fellows providing a Grand Rounds presentation on the topic of their choosing that they've developed an interest in and developed really an expertise in over their 3-year cardiology fellowship. Today we have two speakers, both of our co-chief cardiology fellows, who are going to provide their presentations. For the audience, please go to pollev.com and enter DeBakey to interact with us and ask questions. Or you can also join by text by texting DeBakey, D-E-B-A-K-E-Y, to 37607. And if you text in your questions, we'll be able to engage our speakers in the Q&A. So without further ado, I'd like to first introduce Dr. Salil Kumar. Dr. Kumar did his undergraduate medical education at Ohio State University and did his internal medicine residency at Montefiore Hospital before we were able to recruit him down here to do his cardiology fellowship training. He has really excelled during his training here and has been, again, serving as the co-chief cardiology fellow. And we're lucky to have been able to recruit him again to stay on with us for his advanced heart failure and transplant cardiology training. Throughout his cardiology fellowship and starting, I believe, in residency, his research focus really has been on the development of right ventricular failure following LVAD implantation. He truly has led the creation of a multi-center consortium with Ohio State, Montefiore, and now Houston Methodist to improve prognostication of right ventricular failure after LVAD and its management. This really has culminated in lots of research productivity as well as a presentation at the latest ISHLT conference, and really he has developed the largest sort of consortium with a patient registry that's exceeding over 1,000 patients. So it's really a pleasure, and we're really looking forward to his talk today, titled Machine Learning in Heart Failure, Disruptive Tool or Fool's Gold. So, Dr. Kumar, you tell us.
Thank you guys for having me. I'll be presenting today Machine Learning in Heart Failure, Disruptive Tool or Fool's Gold. I will not discuss off-label use and or investigational use of drugs or devices. And I'll be discussing some of our research from our RV Post-LVAD consortium. Here are the disclosures for my co-investigators. So our primary objective today is to have participants understand the importance of learning about machine learning to their future clinical endeavors. Participants should be able to define supervised and unsupervised machine learning and each approach's pros and cons. Finally, participants will learn how to analyze a machine learning study through using heart failure examples as case studies. We will not be teaching you how to become a computer scientist. We will not be teaching you how to code a machine learning algorithm or expect you to learn the nuances of each machine learning approach so you guys can all relax. We will be giving you the vocabulary to start understanding this important field. Machines will not replace physicians, but physicians using AI will soon replace those not using it. No machine learning talk would be complete without this quote from Dr. DeLeva from a Lancet editorial in 2019. Our hope is that we leave here today not being afraid of machines and machine learning, but we can soon embrace machines as a tool that we can use to help our patients. Machine learning is coming to a clinic near you. It's coming to an EHR near you. It's coming to a radiology station near you. This editorial from JACC, the State-of-the-Art Review by Dr. Quare et al., shows that the number of cardiac publications in machine learning is exploding recently over the last 10 to 20 years, and specifically over the last 10 years. And the applications to machine learning embraces all different fields of cardiology, from atherosclerosis to arrhythmias to heart failures, as we will see. First, let's define artificial intelligence and machine learning. Artificial intelligence is the ability of machines to perform tasks that normally require human intelligence. Subsequent to that, machine learning is a set of computer algorithms that can learn complex patterns from data, thereby enabling artificial intelligence. So here is a pictorial representation of the nesting of machine learning in the definition of artificial intelligence. As you can see here, machine learning is split into supervised and unsupervised approaches. There's an alphabet soup of different supervised approaches, including support vector machines, decision trees, ensemble machine learning, or Bayes. For unsupervised learning, you have principal component analysis or clustering, to name a few. The goal of this talk is not to understand what each one of these different algorithms do, but to understand what is supervised versus unsupervised learning. And nested within this, deep in this diagram, is neural networks, and neural networks serving as a tool for deep learning. These kind of machine learning algorithms are best to approach highly complex granular data sets that are frequently used to, for example, analyze EHR data or the collection of pixels that make up a medical image. So supervised learning is when you both have an input and a labeled output. For example, if you give a machine a stack of EKGs, you'll be giving the machine the 12-lead EKG and the human reading of what that EKG is, so the machine can learn to identify that output. In an unsupervised learning approach, the machine is fed the data without any labels, and will identify patterns in the data that is not subject to human bias. So to delve further into what supervised learning is versus unsupervised learning, supervised learning has a clear goal, which is to predict the label of interest. This constrains the algorithm's ability to find a clear pattern in data. There are data set limitations to using supervised learning. First is that it's very labor intensive. You need a data set that has been labeled accurately. So for example, if you're trying to teach your machine how to read EKGs, if you have a stack of 1,000 EKGs, you need accurate reads on 1,000 EKGs in order to make sure that the machine learning algorithm is taught properly. So frequently, this can be a huge limitation to using supervised learning. It's one that you need to put in the time and effort to make sure that your data is labeled adequately, and two, that your data is correctly labeled. On the contrary, we have unsupervised learning, which is beneficial to discovering new novel groups of data points, and it's free of labor-intensive labeling. And the groups that we do find using unsupervised learning has to still be validated clinically. There is a third type of machine learning that we're not going to be talking about today called reinforcement, because it's not used as often in the clinical setting. So, great, we have a machine learning. Now what do we do? The most important part is testing that the machine learning algorithm is working as you anticipate it to work, and that can work in data sets that are not your own. So the derivation data set is the data set that we use to come up with a machine learning algorithm, and the test cohort or data set is the one that we test our machine learning algorithm on. Frequently, investigators can take their cohort and randomly divide them into a 70-30 split, for example, or a 60-40 split, for example, and develop their algorithm on their derivation cohort, which has been randomly assigned and is completely independent from their test cohort. And ideally, the ideal situation would be that the machine learning is independently tested on external medical center data sets. And the more data sets that you validate your machine learning algorithm on that's external to your own, the more valid and generalizable you're proving your machine learning algorithm to be. The Achilles heel in machine learning is overfitting. So overfitting is when the machine learning algorithm performs markedly better on the derivation cohort compared to the test cohort. And this can occur for a couple of reasons. First, if your machine learning algorithm is too complex and you're using a very small sample size, for example, your algorithm can essentially memorize the rules for the conclusions that it's reaching instead of learning patterns in the data to then apply to other data. If your machine learning algorithm has trained too much, then it will again start to memorize rule rather than understanding patterns of data and learning how to assess patterns of data in the future. Next, we have class imbalance. Class imbalance refers to using where one of your your study points of interest is has a very low sample size. So for example, if you're studying right heart failure and trying to predict the severity of right heart failure, if you have only 10% of your patients who have severe right heart failure, that's a huge imbalance in your cohort and can lead to what we call a class imbalance and an inability to predict severe right heart failure in test cohorts. So essentially, the more data that you feed your machine learning algorithm, the better. There are a couple things we can do to avoid overfitting, and these include reducing the model complexity, increasing the number of examples in the training set, but this can be, sometimes not possible because you're limited by your overall sample size, limiting the number of iterations of algorithm on your training data. You can balance the parameters learned in the model. This is called regularization to obtain a simpler model. So instead of having a model that has 100 variables, try to get to a model that has 30 or 40 variables, and making sure that this new model that's simpler underfits the training data so that it generalizes to your test data more easily. And finally, you can use not one model, but an ensemble of models, which is a more complex approach that can be well worth your time. Next, we're going to discuss how we assess whether or not your machine learning tool is any better than the traditional approach. We use old players that we should all recognize, like discriminatory power, so plotting sensitivity versus specificity on the X and Y axis, and developing what the RC curve for that machine learning algorithm is. As a refresher, the C statistic of 0.5 is as good as flipping a coin in terms of predicting RV failure. A C statistic over 0.7 refers to a reasonable discrimination, and over 0.8 refers to strong discriminatory power. We can also use calibration as we do for other risk prediction models and using the Hosmer-Lemon-Show test. Calibration refers to assigning average risk of an outcome to a population. So a perfect calibration would be if the observed outcome is the expected outcome. In the case of overestimated the risk, the observed outcome occurs less frequently than the estimated outcome. And this is the most common scenario we'll see in machine learning, where we have overfitting. Next, we have precision, which refers to if a test predicts a positive event, it's correct what percentage of the time, so your true positive plus your false positive. You have recall, which is analogous to your sensitivity, as you can see from this equation. And we have accuracy, which should also be familiar, which is the total amount of to correctly identify true positive and true negatives over your sample size. So machine learning is advantageous over traditional statistical approaches in a couple of scenarios. It's advantageous when trying to detect data patterns from an unbiased lens, free from your human bias. It's advantageous when assessing non-linear data. Traditional statistical approaches fall apart when used on non-linear data. Particularly, machine learning approaches are best for big, complex data sets with hidden intervariable associations. The bigger your data set, the more granular your data set, and the more likely a machine learning approach would be more suitable than a traditional statistical approach. Machine learning algorithms have the advantage of being able to be adapted and retrained with continuous data input and improve with time. There are some pitfalls to machine learning. One is the generalizability of the learned rules from the algorithm to other data sets, as we have discussed. There's issues with cross-modal synthesis. So what this means is, for example, in a cardiologist's day-to-day life, you're evaluating the patient's history, you're evaluating their EKG, vitals, their CT, their echo, and their MRI data, and you're using all these different modalities to come to conclusions about what is the diagnosis, what is the prognosis, and what should be the treatment plan for the patient. Machine learning algorithms struggle with this kind of cross-modal synthesis due to how variable the different data inputs are. And lastly, there's issues with explainability and this concept of the black box conundrum, where we don't really understanding what's happening inside the box, which is the machine learning algorithm. So machine learning absolutely has heart failure applications, as we can see here from Dr. Quare's state-of-the-art review. There are a significant amount of papers in the machine learning surge that we've seen that are about heart failure. The most common AI and machine learning methods includes neural networks, which we'll not be discussing today. And some of the most common in heart failure, from my own observations, are probably clustering, Bayesian, and decision tree analyses. So we will be now applying what we have just learned to heart failure applications. And so we'll also be using the toolbox from Dr. Quare's JACC State-of-the-Art review on machine learning on how to approach a heart failure paper. We'll start by using Dr. Sanjeev Shah's work, and I think his work in machine learning was the epitome and the gold standard of how to approach a heart failure population and to use machine learning in a way to advance the science and biology of heart failure. So the paper we'll be reviewing today is his work from 2015 in Circulation, Phenomapping of a Novel Classification of Heart Failure with Preserved Ejection Fraction. So the first question from the toolbox that we should be asking ourselves is, what is the problem being addressed? Is it solving the problem impactful for medicine? In this case, yes. We knew by 2014 that HFpEF was a highly heterogeneous population. We had multiple large trials with ACE inhibitors, ARBs, mineralocorticoids at that time that failed at proving benefit for the HFpEF populations, and that was probably due to this being a heterogeneous population, and that was their hypothesis. So what is the current state of the art, and how does it perform? At that time, there was no highly accurate, scalable, or efficient classification system for HFpEF, and we're still kind of struggling with that today. So does the problem need a machine learning solution? So as we discussed, machine learning is best for complex nonlinear data, and in this case, complex nonlinear data was definitely suspected. The patients involved in this were included data from the electronic health record, included data from imaging and echocardiographic data. So yes, this was an appropriate problem for machine learning. As we said, HFpEF is highly variable. There are many different pathophysiologies, as you see here, that affect HFpEF, and there are multiple different risk factors that lead to heart failure, as we can see here. So this is absolutely a heterogeneous population that requires probably an unsupervised approach. Next, we have to ask, what benchmark is the machine learning solution trying to beat? And so here, they were trying to beat BNP for the risk stratification for mortality. They were trying to beat the MAGIC score, which had been produced at that time, and the HFpEF2 score was not there at the time. So those were the benchmarks we were trying to beat. Next, what machine learning approach was used, and is it appropriate? The machine learning approach that was used was hierarchical unsupervised learning. We don't expect you to understand what this exactly means, but understand that this was an unsupervised approach. An unsupervised approach here was appropriate because they were trying to assess patterns that we could not see due to our bias as a human and not being able to take into account all the different data coming in for our HFpEF patients. They then used penalized model-based clustering of participants to identify how many different clusters they needed of patients that would be best for this hierarchical approach. Next, we have to ask ourselves, if unsupervised learning is used, what methods will be used to validate the pattern learned by the model? Here, they use cardiovascular hospitalizations or death as their primary outcome, and their secondary outcome was heart failure hospitalizations. So here is a visual representation of what the hierarchical clustering algorithm was doing. I think the first takeaway we have from this is that what the algorithm is doing is highly complex and it's hard to recreate from a traditional approach. Here, these columns of data are individual patients, and these rows of data is a heat map of the different phenotypes of characteristics that they do have. Red indicating a high-level association with that phenogroup, and blue being a low-level association with that phenogroup. In general, clustering analysis is the task of grouping a set of objects in such a way that objects in the same group are put together, which are clusters, and objects that are very dissimilar from each other are put away from each other. In hierarchical machine learning, there's a decomposition of data in this tree-like format. So the phenotypes that they obtained were phenogroup number 1, 2, and 3, with 1 being a BNP deficiency syndrome, 2 being an extreme cardiometabolic syndrome, and 3 being an RV failure cardioabdominal renal syndrome. So as you can see, even though there are about around 40 variables for these different groups that they're based off of, the authors were able to deconstruct what are probably the most important characteristics of these groups and help describe what these groups are for us so that we are able to understand what these phenogroups represent. They then used after they had established what their clusters or groups were, they're able to then clinically associate them with hard outcomes, as we see here in figure 3 and this other figure on the right. They not only tested that these outcomes were valid in their test cohort, but then showed that these outcomes and stratification stood up in their validation cohort as well. So now we have our last set of questions, and they include, is the training data set appropriate for the task at hand? So they had a moderate sample size of an N of 397, and the question primarily refers to, are we going to be able to avoid overfitting? Ideally, you'd have as many sample sizes as we can, but in heart failure, we're limited to having such large granular data sets. So I think it was adequate. Next, we ask, are the validation and test data sets independent from the training data set? And so the validation data set was definitely independent. It included the next consecutive 107 patients that presented at their Northwestern HFpEF clinic that were not included in their training data set. Are all data sets points being processed or manipulated in the same manner? The processing in this case was not described, but I suspect they were, as all variables were continuous variables. Next, these are questions that I think we should ask and not included in the toolbox described by Quare at all, and is how are missing values handled? Missing values were imputed, and the missingness ranged from 0 to 24%. This is very important to keep into consideration when assessing the externalizability of these results. And then how were the candidate variables selected is very important as well, and make sure to read the fine print of how they got to their variables. Here they had 67 continuous variables, and they set up a correlation matrix, and they were able to eliminate variables that had high correlation with each other and got down to 46 continuous variables. Next, we'll be talking about my Post-LVAD RV failure consortium. The Post-LVAD RV failure consortium includes institutions from Ohio State University, Houston Methodist, and Montefiore Medical Center, with Dr. Smith, Dr. Guha, and Dr. Sims playing a pivotal role in helping us put together these data sets and being mentors for us. I'll be talking about our foray into artificial intelligence, and here are co-investigators from Rice University that we're fortunate to have. So we have Dr. Lee here from the Department of Statistics, and his graduate student, Dr. Lin, from Rice University as well, who have helped us in incredible ways. So the Post-LVAD RV failure consortium is a multi-center retrospective cohort of 826 consecutive patients, received a HeartMate 2 or HVAD between January 2007 and December 2017. We're currently adding more patients from 2017 to 2021 to get our sample size over 1,000 patients. We defined RV failure for our project as unplanned death or death from RV failure, which is the acute severe definition of severe RV failure from the Intermax registry. We chose an unsupervised approach called K or prototype. The algorithms that you guys will most likely recognize as K-means approach. A K-means approach uses all continuous variables, whereas a K-prototype approach includes continuous and categorical variables, which we had. Here are the final clustering variables we came down to. We were able to parse them down to 10 variables in total, as our goal was to make this as clinically relevant to the clinician at the bedside. And so we had hemodynamic data, we had lab-based data, and patient characteristic data here. So just to give you a visual representation of what K-means clustering does is that the K-means clusters partitions the observations into a K amount of clusters. You have to find the amount of clusters that would be best suited for your data set through the algorithm. So cluster data points that are similar to each other end up in one set. So here's the centroid, or the middle of the cluster, and data points that are closest to it are the most similar to that centroid. And here we have different centers which are very dissimilar from each other. This is not from our own research, but an example. So we found 3 different phenotypes. We found phenotype 1, which is an acceptable risk phenotype, which is the comparator phenotype. These patients had a mean age of 53 years old. They had an Intermax profile of greater than or equal to 3, and 70% of patients had borderline hemodynamics, normal labs, and a normal-ish BMI. Phenotype 2 was our obese patients with high PA pressures. These are patients that were slightly older. They had a high BMI with an average over 30, and they were very sick patients, mostly Intermax 1 and 2. They had an elevated ANC to ALC ratio, and they had high diastolic pulmonary gradients, TPGs, and PVRs. Phenotype 3 was our old, fragile and inflamed patients. These are our oldest patients in the cohort. They had the highest ANC to ALC values, they had normal cardiac index, and they had the lowest BMI and the lowest hemoglobin, indicating that maybe they were fragile patients. We were then able to correlate our phenotypes with outcomes in our derivation cohort. And so we can see here that cluster 2 had the highest event rate for unplanned RVAD or death at 17.4%, and cluster 3 had a 9.5% event rate. Our baseline cohort had an event rate of 5.1%. For length of stay and 1-year mortality, cluster 2 and 3 performed similarly, and they were significantly longer, and 1-year mortality significantly higher compared to cluster 1. So overall, when applying machine learning to heart failure, what will determine whether or not this technology will be a disruptive tool or whether or not it will be fool's gold is whether or not we stop at just phenotyping our patient. So importantly in these studies, after we phenotype these patients, we should be examining and investigating the biology of why these different phenotypes exist. And then furthermore, we'll then find interventions for these specific biology and these specific phenotypes. This will determine whether or not the field of heart failure is disrupted for the patient population that you're studying. At the end, I think clinicians must lead. Clinicians should be involved with helping to come up with these algorithms. Here's an assortment of roles proposed by Dr. Quer et al. And how non-machine learning experts, such as clinicians, can help bring machine learning to the cardiology clinic as a whole. In conclusion, we have some main takeaways. Machine learning studies are on the rise and applications are far-reaching and affects us in heart failure in particular, as well as we try to find different phenotypes of patients that have traditionally been diagnostic dilemmas for us. There are supervised and there are unsupervised learning approaches, and they both have distinct advantages. With the unsupervised learning, a distinct advantage being that we're able to find trends in data that are not subject to human bias, but we have to clinically correlate this. Machine learning application in heart failure require big, granular, multidimensional data sets with adequate derivation and validation sets in order to be a truly successful application. Recently, with heart failure studies looking at UNOS databases and Intermax registries, these data sets aren't as granular, and so there's difficulty being seen in separating themselves out in terms of ROC curves compared to traditional approaches. Finally, phenotyping should not be the end goal. We should strive to push the biology and that will help us inform interventions for these particular phenotype groups. Thank you, everyone, and I'll take questions.
Great job, Dr. Kumar. Thanks for the nice overview on machine learning. Just in the interest of time, I'll maybe start with one question as our audience continues to contribute questions either by pollev.com or by texting DeBakey to 37607. Sal, so I'm a clinician, and I'm glad you started off the talk by saying that you're not going to turn me into a computer scientist or a machine learning expert. But as you pointed out, there's lots of studies now that are coming out about machine learning, and phenotyping is a really big buzzword that's really giving us new insights. How does one go about critiquing a paper that's based on machine learning? What are some of the inputs that we should be looking for to say, how is this valid? Because at the end of the day, as you pointed out, one of the challenges that can come across with these machine learning-based papers is this black box conundrum and the explainability of this data that you may get from it. So how does one go about actually critiquing one of these papers before we can apply it to the patient?
Absolutely. Thank you for asking that question. In terms of critiquing a paper, I really recommend everyone review the JACC State of the Art paper by Dr. Quer et al. About machine learning. They give us this toolbox, and that's where the questions that we went over for the HFpEF paper came from. And so it breaks down step by step how to answer and critique and view a machine learning paper. And the more times that you do it, the more that you'll become comfortable doing it. In terms of how do we make sure that this machine learning paper or algorithm is relevant to us, I think it's incumbent on both the investigators to convince us that it is relevant to us, and then 2, that we are assessing it critically. So we need to make sure that we're studying the population of interest. We have to make sure that machine learning algorithm was even a valid approach to begin with. Just because we use machine learning doesn't mean that it was a valid approach to begin with. And then making sure that we assess what are the metrics for that algorithm. So looking at the ROC curves, looking at the calibration curves, looking at the precision, accuracy, and recall data sets, are data for this. And then finally, you bring up a hot buzzword topic for machine learning, which is explainability and this black box conundrum. So the black box conundrum was first described by Dr. Topol, and it's this idea that these machine learning algorithms, such as deep learning, we don't know what are the inputs and how are they coming to the conclusions that they're coming to. And so we have to make a trade-off. We can say it's okay that we don't know what is going on under the hood, as long as we're getting 99% accuracy or a very high accuracy in terms of predicting our end outcome. And the alternative is using an inferior approach and accepting just to know that what are the inputs into this machine learning algorithm, and accepting a lower accuracy. So for example, choosing an 80% accuracy instead. And so it's something that we as humans have to come to grips with, and understanding that we don't necessarily know everything that is going on, and accepting that we need to do the best for our patients and accept a 99% accuracy.
Great, thank you very much. Moving on, it's really my pleasure to introduce Dr. Joe Aoun. Dr. Aoun actually did his undergraduate medical education at the St. Joseph's University in Lebanon before completing his internal medicine residency at the St. Elizabeth's Medical Center at Tufts University. And again, we were fortunate enough to recruit him down here to Houston Methodist for his cardiology training. Again, he's been a stellar colleague even from the start, and he is serving as one of our co-chief cardiology fellows. And again, we're fortunate to recruit him to stay on as an interventional fellow. Dr. Aoun's focus has been on the structural heart interventions. He's published multiple articles and book chapters, and he is now working on the STS and TVT national database to study the outcomes of a clip and ring approach. And so today we're going to hear about his work that led to the research question, and his talk today is titled Recurrent Mitral Regurgitation After Surgical Mitral Valve Repair, the Insights on Mechanism and its Management. So, Dr. Aoun.
Thank you, Dr. Kim, for the very nice introduction. So as Dr. Kim mentioned, we're going to focus on the insights and the mechanism of recurrent MR after surgical mitral valve repair. And to disclose, we've received a recent grant to work on the National Registry for clip and ring outcomes, which is actually relevant to our topic today. In terms of outline for the talk today, we're going to discuss a little bit about the anatomy and function of the mitral valve, the epidemiology of recurrent MR, the types of mitral valve surgeries, as well as the mechanism of that recurrent MR and what to do in terms of management and some future perspectives. So first, in terms of mitral valve anatomy and function, it is really important to know how the mitral valve apparatus is not only the leaflets by itself. So as you can see here, the leaflets are very smooth, they don't have calcifications, they float pretty well, they have pretty good apposition, which is the size where we have contact. At the same time, there's this commissural leaflets on the sides that the surgeons try to preserve. By that, if we don't preserve those commissural leaflets, we'll have MR by itself. The second step is looking at the annulus. So the annulus is not just a fixed string or anything. It consists of a saddle-shaped fibrous tissue that interacts with its surrounding. It interacts with the aortomitral curtain anteriorly, and then we can see here a concave shape during systole and a convex shape during diastole, allowing flow to go from the left atrium to the left ventricle. The pap muscles, where some fine marginal chordae go into the leaflet tips, Those chordae are very important to decrease the risk of having a flail leaflet. There are some coarse or more thicker basal chordae and intermediate chordae going to the base and the mid of the leaflets to decrease the risk of billowing and decrease the stress on the leaflets. And finally, the left atrium has played a major role with our recent sort of description of atrial MR. By dilatation of the left atrium, you'll have a larger annulus as well and malcoaptation. So for epidemiology, between 2011 and 2016, there has been around 115,000 operations done for isolated primary MR, not counting other surgeries that involved multiple valves or other surgeries that actually involved functional MR. And between those, according to the STS registry with the adult cardiac surgery database, the surgical mitral valve repair has occurred in only 65% of the cases, despite that we know that mitral valve repair is actually has better outcomes in terms of morbidity and mortality for patients. So in around 35% of the cases, those mitral valve were not repairable and mitral valve replacement was occurred. So specifically for the mitral valve repair, usually those surgeries occur in degenerative leaflet prolapse, predominantly in the posterior mitral valve leaflet. Secondary, we can see it in rheumatic disease or ischemic cardiac disease or non-ischemic cardiomyopathy for functional MRs. Going further, why are we talking about this topic? Recurrent MR is not as uncommon as we thought. There are plenty of variable data that showed that recurrent MR in the posterior mitral leaflet occurs in around 20% of the cases, but other reports have went up to even 80%. On the other hand, anterior mitral leaflet and bileaflet repairs had recurrent MR in about 50s to 60%. But this is different depending on the centers. At Houston Methodist, our rate of freedom from recurrent severe MR at 10 years has been 4%, and the reoperations have been 4% at 10 years. Also, Cleveland Clinic had similar experiences with around 7% freedom from reoperation at 10 years, despite that we do some surgical techniques a little bit differently. The differences between studies are mainly because most of the studies are observational. The other thing is the difference in echo reading, echo readers. The third thing would be the differences in techniques that are used for mitral valve surgical repair. And lastly is the experience of the center. We note that the large centers have actually better outcomes and less rate of recurrent MR. So recurrent surgical repair strategies have evolved throughout the years. So in the 1950s, they were focusing more on suture annuloplasty or commissural fusion, and as well as leaflet plication. And that has evolved with the Carpentier technique, which is the French technique, in 1980s, around 1983, when he thought that actually the problem is not only in the leaflet, but also in the frame of that leaflet or doors. And he introduced the rigid ring as well as surgical repairs with the classification of type 1, type 2, and type 3 that we know. The type 1 being the leaflets are normal or have only a perforation, type 2 being the prolapse or the flail mitral leaflet, and type 3 being the restricted mitral valve leaflet related to either diastolic restriction or systolic restriction depending on etiology. And he coded or basically developed techniques to specifically treat each and every one of these types of regurgitations. And in the 1990s, towards early 2000s, Dr. Gerald Lowry actually described the newer technique, which is the dynamic mitral valve repair, which is the American technique. And this has evolved progressively, and we're going to discuss that later in our talk. So at this point in time, we're able to do resections or non-resectional techniques. We're able to do artificial chordae, annuloplasty, and prosthetic rings. The traditional Carpentier technique, which is the French technique, as I mentioned, consists of using a rigid ring with a 4:3 ratio. The sizing of that ring is based on the mid-systolic dimension, which sometimes limits the flow during diastole and can cause a little bit of an increased mitral stenosis effect or a gradient between the LA and the LV. It also consists of quadrangular resection, mainly for the posterior mitral valve, For the anterior, it's usually triangular resection. The repairability of the Carpentier technique is around 50 to 70%, as we've seen with the STS registry. Also, failure at 10 years is around 20 to 30%. The risk of SAM can be up to 1 in 5 patients, which is very high. And as I mentioned about the mitral stenosis. And here you can see in the slide, the first image on the left, this is actually a flexible ring and not a rigid, but let's imagine it's a rigid ring, and it goes from the trigon on the left side to the trigon on the right side, which is a bit low, causing, if it's rigid, causing the anterior leaflet motion to go into the LVOT and increasing the risk of SAM. On the other hand, the American technique on the right side, where we suture the flexible annular ring a little bit higher, allows the mitral valve leaflet to go backwards and upwards during systole and decreasing the risk of having SAM. So for the procedure that Dr. Lowry actually described very well, we use fully flexible complete annuloplasty rings. We use artificial chordae made of Gore-Tex, and we do some simulation intraoperatively. There is no leaflet resection at all, which implicates further transcatheter repairs and management. And also, for the outcomes, the recent published data in 2021 by Dr. Lowry, the repairability was around 100%. And the perioperative mortality was around 1.6%, and the survival at 10 years was around 75%, with a reoperative rate that was only 4% at 10 years. And as you can see here in this video, the flexible ring actually goes with the motion of the native annulus. And you can see here that concave shape and the convex shape that we've discussed during systole and diastole, allowing a good flow from the left atrium to the left ventricle. And this is the dynamic insufflation that is being done during the surgery, where fluid is injected inside the left ventricle and inside the aorta to mimic the end diastolic volume and the increased afterload that the mitral valve can face. And the valve is assessed for any leak. On the other hand, there's another concept that is called end diastolic locking, is actually when the left ventricle gets to the end diastolic volume, the mitral valve leaflet come close together and become almost opposed and decrease the risk of early systolic MR. So what are the mechanisms of failure of these surgeries? First, there's the leaflet stress, and Dr. Salgo in 2002 in Circulation has published that the stress on the leaflets increase dramatically when it's in a fixed ring, when there's no leaflet billowing, which we can see in the Carpentier technique, and that's compared to normal controls where all the blue is like stress-free, sort of. Other mechanisms of actions were actually described by Fleming, which can be the lack of annuloplasty ring, and that means by the time the annulus could dilate and there would be malcoaptation. Using chordal shortening, usually this technique by Carpentier for type 2 MR, when you have a flail or like a prolapse, you can do a chordal shortening. This has showed that recurrent MR is more common than using neocords or artificial chordae. And third thing, the lack of use of sliding plasty of the posterior annulus dilatation, and working or repairing the anterior or by the bileaflet or the bileaflets has a higher risk of recurrent MR. Other described mechanisms are the dehiscence of the annuloplasty ring, and we know that the rigid rings, just because of they're rigid, there's more stress on that annulus and they can dehisce more frequently than the flexible rings. In that area, with time, there would be an annular dilatation and more malcoaptation and more MR. We discussed about the stress on the leaflets, and the next one would be actually the underlying etiology of the disease, whether it's a cardiomyopathy causing functional MR or whether it's a myxomatous disease or a Barlow's disease that recurs or sort of evolves with time and causes the repeat MR. And finally, sometimes the surgeons can create iatrogenic MR by the SAM, and you'll have a posteriorly directed jet. So at this point in time, according to the most recent published data from 2018 in the STS registry, the surgical mitral valve repair has consisted from resectional, which is primarily Carpentier technique or some variations of it, and then the remaining being non-resectional, part of which is the dynamic mitral valve repair. And the artificial chordae, despite that they have been beneficial to decrease the recurrent MR, it's only seen in about 29%. So what can we do when we have recurrent MR. Is reduced surgery an option? It is an option, but definitely those patients by then have more comorbidities. And if we compare the reduced surgery to the primary surgical surgery or of isolated MR, there is definitely more mortality and morbidity, with 11.1% of in-hospital morbidity and mortality, and a higher length of stay. At the same time, if we use all our predictor models, the observed to expected ratio of mortality is actually high, and higher than we think. Therefore, that has led to the use of transcatheter therapies in terms of transcatheter edge-to-edge resection or transcatheter mitral valve replacement, and other techniques that are having more of safety and feasibility data with time. So here we can see some of the repair techniques that can be used, and the replacement. Mostly the replacement at this point in time is with a sapien valve and not the new devices. Going further, there hasn't been any decisional algorithm that guide us. So in our institution, we've created sort of an algorithm that help us make the next step. First, we assess our patient. Is he at a low surgical risk with an STS of less than 6%? Do they have no porcelain aorta, severe pulmonary hypertension, or a severe liver disease? If all of these are negative, we discuss with the patient and inform them that actually the risk of the surgery is higher than our predicted model, but then the risk remains low, and this might be an option. The next step, if they don't meet those criteria, is to look into the transcatheter options. A TEE is a must in order to determine the size and the nature of the ring if we don't have the surgical report. But also it determines whether we can also grasp the leaflets. And if a MitraClip or a Pascal device cannot be implanted, then a valve and ring might be an option. So here's the clip and ring procedure. What are some determining parameters that can help us determine whether we can do this type of procedure? The ring is actually artificial, and it can cause acoustic shadowing. So during our TEE, we go to the grasping view and make sure that the leaflets, and predominantly the posterior leaflet, is visible. The next step is to measure that leaflet. Is it long enough to be grasped? Our cutoff has been around 6 to 7 millimeters. There's no hard data on that, but this has been the experience. And the third thing would be the flail gap and the flail width. Despite that the Everest trial recommended the 10 and 15 millimeter cutoffs, this is falling out of favor because of the 4th generation MitraClip and Pascal devices that can grasp even longer. And we can put more than one clip. So here we can see in this case, in the first image on the right, or the video on the left, sorry, there is a systolic anterior motion causing some LVOT obstruction in addition to an MR. The middle panel shows that the MR is moderate to severe. Here we have our wall filter increased, so it doesn't show enough of the MR yet. But also in the third one, we see on the 3D TEE that systolic anterior motion is causing the LVOT obstruction. And after placing a clip, that systolic anterior motion is gone and the MR got better. Do we have data about clip and ring? There has been several observational studies that had a sample size of 12 to 50 patients, but the largest one has been published in the Netherlands by Dr. Van Meegem, where Dr. Little here and Houston Methodist contributed to the manuscript, as well as providing the data for our patients here at Houston Methodist. And that was a multi-center observational study demonstrating that those patients had rings in about 87% of the cases. The rings were complete and not only a band in about 70% of the cases. During the procedure, they had to place 1 or 2 clips in the majority of the cases. And also, the MR reduction was at least grade 1 or it improved by 1 grade or more in about 94%, with a technical success rate of 90%. And as you can see, the follow-up period was about 1 to 6 months, and the majority of the patients, which was about 85%, had an NYHA of 2 or less. And in addition, the MR reduction was maintained in about 80% of the cases where it was where it was moderate or less. This led to us looking at longer outcomes at 1 year, and in our cohort here in the hospital, we have seen that around 92% of the patients had NYHA 2 or less at 1 year, and and about 82%. Also, the MR reduction of moderate or less was seen in about 92% at 1 year. The next step, if the patients are not eligible for clip and ring, then valve and ring would be an option. And a cardiac CT is definitely important in order to understand the valve annulus dimensions, but also the risk of LVOT obstruction. So looking at the aortomitral angle, whether it's less than 115 degrees, it increases the risk of LVOT obstruction. Trying to size and predict the neo-LVOT with some simulations. Also looking at the septal diameter and looking at whether the ring was sewed high enough or low on the mitral valve leaflet. And finally, also the CT can help us looking in the intraatrial septal anatomy, looking at the type of and size of the ring. So here we can see that the optimal ring that favors valve and ring is actually a complete, flexible, and semi-rigid ring. Because when it's rigid and you're inflating a valve, it actually becomes oval shape, and the ring does not take the form of the valve. And you'll have some leaks, as we can see here in the first image above, on both sides. Compared to when you have a semi-rigid, the ring takes the shape of the valve and the balloon, which becomes circular, and there would be no leaks. On the other hand, when you have a band or an incomplete ring, there would be some instability anteriorly when you're deploying a valve. In this case, we see an anterior mitral leaflet flail that was treated with a valve and ring. And after the result, we can see some mild or minimal paravalvular leaks at 6 o'clock and at 11 to 12 o'clock. How about the data of the valve and ring? And Dr. Guerrero has worked tremendously on the topic and has published the STS registry in 2017 with about 123 patients. The morbidity and mortality was actually significant, and the in-hospital mortality was around 11%. Was around 9%, which increased to 11% at around 30 days. And prospectively, that was studied in the mitral study that was led by Dr. Guerrero, and the 30 patients that were followed had a 1-year mortality of 23%. The VIVID trial at this time remains the largest registry, including 222 patients, and similar results were seen at 1 year that actually progress at 4 years, being around 50% mortality. What are some future perspectives? The neocord procedure through a transapical approach has actually been used in native valves. But in terms of surgical valve repair that had recurrent MR, there is a small study published by Gerosa looking at 15 patients and having good outcomes. So the MR post-procedure was at most moderate in 100% of the patient. And at 1 month, only 7% had recurrent severe MR. At 1 year, only 9% had severe recurrent MR. The next thing is the AccuCinch, which actually is used in the functional MR, which is a device that is being placed at the base of the annulus and decreases the basal diameter of the left ventricle and the end diastolic volume, and by that bringing the leaflets together and decreasing the malcoaptation. The feasibility study is ongoing on those patients, and hopefully, I think in 2024, they will have all their patients and they can try to publish the data. Transcatheter annuloplasty, we know that some patients, or rarely basically, some patients do not have surgical rings post-mitral valve repair, and there are some direct placement of cardioband mitral system inside the annulus or on the annulus. That was published by the Titan trial that had good outcomes at 24 months. Also, the Carilion mitral contour system that actually showed that if you go into the coronary sinus and decrease that mitral valve annulus size, you'll have better good outcomes. So if you tell me what would be my title of the presentation in 10 to 15 years with the evolving field, I think it's going to be the mechanism and management of recurrent MR post-transcatheter repair instead of post-surgical repair. Finally, in terms of summary, not all mitral valve surgeries are the same. Please choose your surgeon very well. The use of flexible rings and artificial chordae is important, not only for the short term, but for the long term. In case of recurrent MR, it facilitates the use of transcatheter edge-to-edge repair. Cardiologists should understand the differences in surgical procedures. Therefore, having a patient-centered approach and trying to specifically treat the new cause of MR in those patients. And finally, clip-in-ring and valve-in-ring are reasonable options when redo surgery has a high risk. Thank you so much for your attention, and please send us questions.
Fantastic. Dr. Aoun, thank you for that wonderful review and really a thought-provoking presentation. I'm going to address some of the questions that have come in from the audience, and there's a theme that I can potentially group a few of these. So one question says that aside from any anatomic contraindications to a mitral clip, what are some patient factors that would favor more of a transcatheter or percutaneous approach versus surgical approach? And I think we can combine that with one of the other questions that asked, is the bar now much higher to go into the OR now that we have so many of these transcatheter approaches available?
Yeah, so I think these are very important questions. And recurrent MR is not as simple because the patients by then, they have more comorbidities and and they are at risk of having more mortality and complications post-surgery. That's why evaluating the surgical risk is not always enough, especially with the observed complications post-procedure being higher than our predicted models at this point in time. So we're tending to go more into transcatheter therapies more than before, just because we're more comfortable in doing them. There's more data in transcatheter edge-to-edge repair, as well as more data in valve and ring as well. So understanding that we can do those procedures in a safe manner has led to making us do it more easily in those patients.
One other question for you, Joe, is whether you've come across any data on the impact of reoperation for recurrent MR following a failed repair versus a transcatheter approach on the LV, on the remodeling of the LV following valve intervention.
So there hasn't been like head-to-head comparisons. I think there has been some reports of mitral clip cause leading to some remodeling by decreasing the LV and diastolic volume. That has been published in the European Heart Journal by Dr. Browner. The sample size was not crazy high. It was around the 80s. There was another paper published in the European Heart Journal that also looked into 180 patients. Remodeling exists and can happen, but definitely that has not been compared between redo surgery versus clip and ring.
Fantastic. In the few minutes remaining, we have a couple of questions here for Dr. Kumar as well. Dr. Kumar, one of the audience says, heart failure is still a place where the art of medicine is needed, and there's still a lot to be discovered. How do you reconcile the practice of art of medicine in valuing the utility of machine learning and its applicability to the field of heart failure?
Thank you for that question. I agree, heart failure is definitely an art. But with the amount of data that we have to process for each individual patient in terms of looking at their full history, looking at their EKGs, CTs, MRIs, and echoes, there's probably some signal in each patient's chart and each patient's data set that we're not able to, in our busy clinic schedules, able to really pick up on. And the machines should really be looked at as a partner in helping us come to the best diagnoses and prognostication and best interventions for patients. It certainly will not replace the art of medicine ever. It's just a partner, and it's a new tool in our toolbox, essentially.
And one last question for you from the audience is that you've identified 3 phenotypes of your own using the machine learning approach for RV failure prediction after an LVAD. So what's next? You said we need to not stop at phenotypes, but also look at the biology and then talk about intervention. So what's next in your research?
Thank you for that excellent question. The next step is for us to validate our machine learning phenotypes in an external cohort, which we're currently doing, and we'll publish more about. And the long-term vision for this is for this consortium to prospectively start collecting blood samples, tissue data, imaging data, for us to get a more nuanced understanding of why these patients develop RV failure. And the ultimate goal would be that we are able to tell our surgeons who needs a preemptive RV support in terms of a Protect Duo or a Centramag before they go into the OR, and help them get through the OR and come out and survive surgery and decrease mortality and morbidity associated with RV failure.
Excellent. Joe, there was one last question, I believe, on the screen from the audience, is that do you feel that the transcatheter or percutaneous approaches to mitral valve interventions will follow the prior trajectory that TAVR did, which is now starts out with the sickest of the sickest that should be treated with this, but now is more accepted and more available? Do you believe that the mitral valve intervention world will also follow suit?
Well, I think it's a very good question. So looking long term, whether we are going to have that, I think at some point it's going to happen. But how the main issue and challenges that we have at this point in time is we're not able to replace the mitral valve in a way where we take care of all the apparatus. So whether we have, like, the chordae, the annulus, and all of that. So the newer devices of putting a transcatheter mitral valve replacement in a native valve can resolve some of the issues and make the function okay, but it's not going to have that fluid motion with all the native that the native annulus can have. Down the road, I think we're going to reach a point where this is going to be replaced, and maybe a transcatheter mitral valve replacement and transcatheter mitral valve repairs using neochordae transapically and placing an annuloplasty with a transcatheter approach is going to be equal. But I doubt that we're going to be able to surpass the surgery because it involves a lot of the function of the valve.
Fantastic. Well, thank you both for just wonderful presentations, and you can see why this is perhaps one of our favorite grand rounds towards the end of the year, when we really see the maturation of our fellows starting as first years and then seeing such remarkable growth and developing into content experts in areas that far surpass most of your faculty in certain areas. So it was really a pleasure. Thank you for the audience participation, and have a wonderful rest of the day.
Thank you.